We will be seeing today a patient who presented with a cardioembolic stroke. During the course of evaluation, he was identified to have rheumatic severe mitral stenosis. Even though he was in sinus rhythm at the time of clinical examination, we don't know whether he had episodes of atrial fibrillation. So we will be presenting a brief clinical history followed by the procedure. And to assist me is Dr. Ashok and brother Dilip Kumar, who is scrub nurse. The cath lab technologists are Mr. Prabhu and I have an imaging expert, Dr. Pramod Sagar, who usually assists me, and he'll be performing an online transesophageal echocardiogram for this patient. Over to you, Anselin. Anselin will be presenting the clinical story of this patient. The discussion will be whether to put in the patient for an open mitral valvotomy, which is on a cardiopulmonary bypass, if we have a strong fear of a left atrial appendage thrombus. The second one will be a balloon mitral valvotomy without engaging the left atrial appendage during the process of catheter manipulations. So what was done in this patient was that he was put on 6 weeks intensive anticoagulation. So he received Coumadin to maintain an international normalized ratio of prothrombin time more than 2.5 for almost a period of 6 weeks, and then he's brought into the cath lab today. The initial part of the hemodynamics, as I show you right now, we have a catheter in the aortic root on the non-coronary cusp, a pigtail, and a diagnostic end-hole catheter in the main pulmonary artery. The main pulmonary artery pressures are around 35 millimeters systolic with a diastolic of around 15 and a mean pressure of close to 22 to 23, showing mild pulmonary hypertension. Now we have to, as Pramod stressed, this is a patient who is under anesthesia, and so some of the hemodynamics will slightly be lower. The aortic pressure from the central aorta is about 120 over 80, and this patient is basically being anesthetized and maintained on a small dose of dexmedetomidine plus propofol sedation by Dr. Uday. Uday is our senior cardiac intensivist.
So what is the site of septal puncture that you plan for balloon mitral valvotomy?
In general, it will be in the middle of the fossa vallis or antero-inferiorly, the closer to the mitral valve. So in certain indications, the septal puncture will be in different locations. For example, when we are trying to do a left atrial appendage device closure, we will be taking the puncture very posteriorly and inferiorly. Similarly, when we are trying to do a mitral valve-in-valve implantation, a transcatheter mitral valve implantation, we will be doing postero-inferiorly. For procedures like mitra clip, it will be postero-superiorly. Now, this is a 8 French Mullin sheath. This 8 French Mullin sheath is now passed on this 035 Termo wire. We go into the left innominate vein. So already the guide wire is in the left innominate vein, and Dr. Ashok is now advancing this Mullin's dilator into the left innominate vein. Once we go into the left innominate vein, this wire comes out. So once I get a good backflow, I next take up the BRK needle. This is a BRK needle with a 45-degree angle, and this needle goes now through the Mullin's dilator. As I am passing it, it's being tracked on fluoroscopy. So it crosses the sacral promontory, it goes through the inferior vena cava, it enters the heart, it goes through the superior vena cava, and it reaches the tip of the needle, tip of the dilator. We have connected a contrast syringe. So right now I'm going to come down live on transesophageal echocardiography on X-plane. So we are coming down on X-plane. I'm bringing it down. We are now entering into the region of the fossa valis, making a gentle indentation of the septum. And now Pramod will rotate right and leftward to see the place where my puncture is. If you get the X-plane onto the needle, then yeah.
Here.
So I'm making much more indentation to find out.
Here there is a mild indentation that is seen here.
Yeah. Now
Minimal
can you rotate
indentation
and
is
show
seen
me
here.
on? Yeah. I'll probably bring down the right now. Can you show
Right
me the
now,
place of my indentation?
no, it is seen here already. It's in that. Yeah, it seems it's already. It's at the region of. It seems it is here at the region of this
Okay. So
fossa
now
ovalis, like on
on.
the superior part of the fossa ovalis.
Okay. I'll make a rightward torque. Again now making. I'm staining the septum now.
Yes, sir. You can see here the contrast is still in the filling the right atrium, and it is at the level of fossa ovalis.
Okay.
Yeah, here.
Is now can you show
Yeah, the
me?
indentation is seen in here now. Well, it is stunting. It seems it's indenting nicely.
Okay.
Here we can see the indentation.
So we
is
can see
happening.
that
It's
we are
already punctured, and the contrast is in the left atrium.
correct.
Here we can see the puncture site.
Okay. So at this position, I take out the needle and connect the needle and connect the Mullin sheath to pressure to document the left atrial pressure. And at the same time advance the pigtail catheter into the left ventricle to record the transmitral gradient. We'll use a wire for entry from aorta into the left ventricle. So now we have the catheter, one catheter in the left ventricle and one catheter in the left atrium to document simultaneous LA, LV pressure in the same scales. We'll analyze the wave patterns. The LV also now will go to 20 scale. And now increase the speed, please. Yeah. So we can appreciate that there is a atrial, the A waves are tall, the V is small, and we have a transmitral gradient that is seen throughout from the beginning of the diastole to the end of the diastole. The patient's heart rate is just about 50 to 60. It's a very slow heart rate, partly due to the beta blocker that the patient was taking and partly due to the deeper level of anesthesia. So we have the left atrial mean pressure of around 16 to 17 millimeters of mercury. Dr. Pramod showed the mitral valve area to be about 0.8 square centimeter, 0.8 to 0.9 square centimeter. The next step in this procedure will be we advance this pigtail wire. The pigtail wire is actually a stainless steel wire. So the stainless steel wire now goes through this Mullin's dilator. And when we are advancing this, we have to ensure that we don't enter the left atrial appendage. So we are advancing the pigtail wire, fluorostore this in such a way that we don't engage. Show this picture again. So we don't engage the left atrial appendage at all. So at this point of time, the venous sheath that has been placed previously in the femoral vein is removed. So this is the pigtail wire that is going in. We ensure that there is no entry into the left atrial appendage. The next step will be advancing a 14 French dilator. This dilator has got a twin job of dilating the groin to facilitate the balloon entry and dilating the intraatrial septa. So we are advancing the 14 French long dilator. So this dilator now goes in and is going to dilate the septum. Can we see the septum?
Yes, sir.
Where it is?
Sure.
So this is the dilatation of the septum that is happening. So what we do is pass this dilator 4 or 5 times across the intraatrial septum in order to facilitate the balloon entry subsequently. I want a small artery forceps, a mosquito forceps to dilate the groin. Yeah. So the next step will be balloon. So now we'll look at the balloon. I hope you are able to see the balloon now. This is like an Inouye balloon. This balloon is called SIM, S-Y-M. This is similar in construction to the Inouye balloon made by the Toray Corporation, Japan. It has got a latex balloon with a fabric. The fabric is peculiarly placed in such a way that when I make the initial inflation, it is always the distal part that inflates first. So this engages the left ventricular side of the mitral valve. As I inflate further, the proximal part inflates next. So this engages the left atrial part of the mitral valve. And as I inflate further, slowly the waist expands and the waist now gets the mitral valve at the commissural level. Now, the way to fix the mitral valve diameter will be based on the height of the patient. So in general, the thought process is the taller the patient, the larger the mitral valve area should be. So this is a patient who is about 170 plus centimeters. So the rule is height in centimeter divided by 10 plus 10. So 170 divided by 10 will be 17 plus 10 will be 27. So we put a caliper to see whether we are somewhere around 27 millimeter. So I have planned it in such a way that this is 27 millimeter. I hope you are able to see the image. So it's a 27 millimeter middle waist.
Yeah.
So now we fluorostore this and show this entry. So now there are some ectopics that has been produced by the tip of the mitral valve. So here you will appreciate that towards the mitral valve, the tip of the balloon mitral valve, the balloon was entering into the left ventricle at this point, and then we make it slightly straighter by bringing down the valve, the balloon, and then engaging deeply inside so that it reaches the tip. So now the next step will be to ensure that it has gone free and there is no restriction. So once we have identified that there is no restriction, the next step will be we make the distal dilatation, pull back and engage the valve. Now we go for the proximal dilatation and the whole balloon came off. So basically what is if the valve is sort of pliable, let us see what was the amount of valve opening. Can you put the
Yes, sir.
Doppler now? Put the Doppler now. Color Doppler.
So,
Color Doppler. Yeah, it's probably some amount of opening is there. There is a little reduction, but what we'll try to do is engage the valve a little better so that the balloon is facing inferiorly here. So we have to face towards the valve. I'll give a little bit of inflation so that the balloon floats in. There are times at which it faces, but the tip is, yeah. I'll reduce the curvature on the stillet a little bit. I will aspirate the blood and flush with saline. And slightly open out the stillet. So I have opened the stillet a little bit now. It's entering the mitral inflow. However, the balloon is facing too inferiorly. I'll give a little bit more inflation. And again try now. I'll probably take off that inflation and reduce the curvature a little bit more. Again aspirate and flush it out.
what do you think is the difficulty? What is the reason for this difficulty in this case?
The probably the puncture was a little bit more away from the mitral valve.
Probably a bit higher.
Yeah. It enters, but comes at an angle. So at that point it's facing.
Faces. Yeah.
It was facing more towards the anterolateral commissure. When the valve is very elastic and what might sometimes happen will be a ventricular ectopic will make a forcible contraction in the post-ectopic beat. Hold it. Okay. Fluorostore this last one. I think the valve is looking a little larger.
Looks a bit.
Can you?
Opening looks a bit better. We'll
Yeah.
see once again.
I will aspirate the blood, connect it to pressures.
It is more laminar when compared to earlier.
Yeah,
It's not much turbulent now.
yeah,
There's no MR again.
I agree
Very
with you.
trivial MR maybe. Too much.
Yeah, I don't find a significant MR.